Good afternoon, everyone. It's my great pleasure to contribute to the 26th annual meeting of the Egyptian Fertility Society and the first ever virtual meeting. We wished that we would be with you in person, but given the COVID-19 situation, we contain the annual contribution. And the title of my talk today is Navigating the Sea of Adhesions, Prevention and Treatment of Asherman Syndrome. Asherman syndrome is a very old surgical topic in gynecologic surgery and in reproductive medicine in general. However, there are some new information that I would like to share with you today. Here are my disclosures. Second disclosure, I want to share that there is a lack of level 1 evidence for comparing expectant management with surgery and comparing the different methods of surgical treatment with each other. In addition, most of the retrospective and the cohort studies that we're aware of, they are including patients with different degrees of severity and different durations of follow-up, which makes it hard to compare head-to-head. And more importantly, there is lack of reporting on obstetrics outcome, particularly live birth rate, and there is no data about Asherman syndrome with IVF or minimal data. Historically, it was first described more than 125 years ago by Fritsch in Germany, and it was popularized by Asherman 54 years later, who took the glory of associating this syndrome with his name rather than sharing it with Fritsch. So in all fairness, it should be Fritsch-Asherman syndrome, if not Fritsch syndrome alone. So what I will try to cover with you is to review with you the risk factors, the current diagnosis, possible prevention strategies, and the current treatment options. And we'll also share with you some information about the possibility of using interventional radiology guidance for managing severe cases of Asherman syndrome, with or without amniograft, and speculate on the possible interventions in the future. So to the best of my knowledge, the endometrium is the most resilient compartment in the human body. It's the only mucosa in the human body that sheds every month in regular paces with rapid mitosis and growth of epithelial cells. Basically, it grows up to 7 millimeter in less than 5 days. It has a significant regenerative capabilities due to the existence of the basalis layer that you can see here. And it's very difficult to destroy the endometrium in the non-pregnant state. So no matter what you do with the patient is not pregnant, you may not be able to destroy the endometrium in its entirety. And the evidence for that is that we do global endometrial ablations for some patients, and then they continue to menstruate after. What is it that is unique about pregnancy that makes the endometrium and the lining of the uterus more vulnerable? There are two factors. The first is the extensive remodeling of the endometrium and the endomyometrial junction that is associated with decidualization and placentation, which makes it more vulnerable. And there is low estrogen environment, which is necessary to promote regeneration of the endometrium. So what happens is the basalis layer is destroyed by one factor or the other. And if it is within the first 4 weeks postpartum or post-abortive, which is a time during which the uterus is most susceptible, then a granulation tissue starts to grow and then form tissue bridges between the anterior and the posterior uterine walls. The most destructive procedure to the endometrium is when we manage missed abortions or incomplete abortion, or postpartum hemorrhage or retained products of conception, and it is the highest risk between 2 to 4 weeks after the antecedent pregnancy, with the risk calculated to be 2-fold higher with 2 DNCs or 2 keratages compared to with 1 keratage. So the more you do DNC on the uterus, the more likely that you'll cause adhesions. In a recent systematic review, the overall incidence after a DNC was calculated to be 19%, which is quite high, with DNC appeared to be the major driver behind intrauterine adhesions. And number of losses also was considered to be a significant factor. So the more miscarriages the patient had, the more likelihood of having intrauterine adhesions. And that is the biggest enemy of the lining of the uterus, sharp curette. So if you want to really prevent adhesions from happening, which was the best you can do for any woman in reproductive age, you try medical treatment to terminate pregnancy, which is very effective. I'm sure a lot of you are aware of the recent New England Medicine article that was published in 2018. And when you combine mifepristone orally 200 milligrams and misoprostol 800 micrograms 24 hours later, you have to up to 91% chance of completing the miscarriage without the need to do any surgical intervention. So the first key message I want to deliver today is that you have to think about referring to medical induction of miscarriage as as a possible first line for treating miscarriages. The second key message, if you have a sharp curette in your tray, take it out. I don't think it's helping that much. You have to do suction curettage, which is more gentler on the endometrium. Sharp curette is a tool that destroys the lining unnecessarily. The third key message is that don't expect a gritty sensation. Unfortunately, we were taught many years ago that we have to do curettage until we feel the gritty sensation. If you're feeling the gritty sensation, you went so far and deeper than what you should. This gritty sensation, you're scraping the myometrium. So you're done with the physalis layer that you need. So you scraped all of this and the physalis layer, and you went down to the myometrium. Watch for your pathology report when you send the products of conception for pathology. If they tell you that there are myometrial cells, then you know that you have to stay vigilant because most likely you induced Asherman syndrome in this patient. Other risk factors include hysteroscopic myomectomy when two myomas are on the opposing surfaces of the uterus, the B-Lynch sutures or the other types of suture that are used for treating postpartum hemorrhage, sometimes IUCDs as well, infection, and in some developing countries, genital tuberculosis. And I haven't seen one patient with tuberculous endometritis a few weeks ago, which was not a good prognosis for sure. So clinically, those patients typically present with abnormal bleeding patterns in the form of amenorrhea or hypomenorrhea most of the time. They develop secondary infertility with cyclic pelvic pain. They are more susceptible to have recurrent pregnancy loss, but a lot of times it's an incidental finding during the investigations of secondary infertility. Different diagnostic modalities are used to diagnose Asherman syndrome, but you can suspect the condition by just doing simple transvaginal ultrasound, and then you finding that the patient is having some sort of interrupted lining or extremely thin lining. If you do not already know that from her menstrual patterns. The classic diagnostic criterion is based on HSG. Hysteroscopy is a gold standard. Transvaginal ultrasound is SIS. Very much virtually replaced HSGs to diagnose Asherman syndrome. And there is a place for MRI in certain patients where there is extensive damage to the lining of the uterus or atresia, secondary to prior attempted failed repair, particularly when you have a gadolinium-enhanced image that showed T2 hyperdense, signifying cavity fibrosis. It's very important to remember there is a high false negative rate with HSG. It's up to 39%. So if the HSG is normal, while you're clinically suspecting Asherman syndrome or intrauterine adhesions, please go directly to hysteroscopy and do not rely exclusively on the HSG. This is an MRI showing an anteverted uterus with segmental atresia of the lower segment of the uterus. This is another patient who has really very much 2/3 of the endometrial cavity is gone secondary to adhesions. So there are different classification systems to classify the disease. The most famous of which is the one that you're seeing in front of you by Charlie March. And if it's less than 1/4, it is mild. 1 to 3/4, it's moderate. And if it's more than 3/4 with agglutination of the uterine walls, it's severe. Excuse me. So what are your goals when you are treating these patients? You are trying to lyse the adhesions and normalize the cavity as a first goal, and you would like to prevent readhesions or recurrence. And also you'd like to not only restore the anatomy, but restore the function. You want to have a normal endometrium that's functioning at the end and able to menstruate or implant an embryo. And of course, there are the post-operative interventions to decrease the adhesions or improve uh, the um, the performance of the endometrium. So hysteroscopic lysis of adhesions using cold scissor is the gold standard, and we do most of these cases in the office where we use saline for distension under conscious sedation with intravenous midazolam and fentanyl, in addition to using uh, paracervical block. So usually we use cold scissors, starts Kodak to Kefalad, with the filmy adhesions being tackled first until you get into the upper part of the uterus, as you can see here, and then you can see both tubal ostia on each side. Usually you keep the lateral or extremely dense adhesions towards the end. It's important to do this under direct visualization and magnification. In some scenarios, the situation is more severe and you have near obliteration of the endometrial cavity. And in these cases, doing ultrasound guidance, as you can see here, is important. When you are in that scenario, all you do is create windows inside the lining guided by ultrasound. You open up and then you start cutting through the dense adhesions guided by the ultrasound monitoring to prevent you from having false passages until you cut the adhesions under direct visualization, and then you get yourself into the upper part of the endometrial cavity. And if you're not seeing the top part with the tubal ostia, you're not completely done in patients with severe Asherman syndrome. There are situations where the two walls of the uterus are completely agglutinated, as I said. This is a patient that has two failed attempts at repair prior to its referral to our center with prior perforation of the uterus in the lower uterine segment with significant retroversion, as you can see. So she saw one of the expert people who counseled her about transfundal hysterotomy and repair, which I disagreed with, and I decided to offer her interventional radiology guidance guided repair. So here is a set that we use for interventional radiology guided repair for severe cases of Adhesions syndrome. And it goes through two steps. The first step is done in the radiology suite, as you can see here. And basically what you do is you try to break into the proper endometrial cavity with a guide wire. And once you are in there, you will be able to introduce a pigtail catheter that goes all the way up. And the way you confirm that you are in the right spot is that you inject dye that showed you the endometrial cavity, and it shows both fallopian tubes as you keep injecting. Here's one fallopian tube, here's the other, and that's the part of the uterus that is obliterated. Secondary to that, you can use a guide wire to dilate even further to allow yourself to get into the endometrial cavity. And then you leave the pigtail catheter inside the uterus like that. And then you move to the second step of the surgery, which is very much taking the patient to the OR and using a 3 mm operative Wolf hysteroscope to go above the guide catheter that you can see here. And you walk your way by cutting the adhesions around the catheter all the way to the top of the fundus of the uterus. And once cutting all of the adhesions is completed, then you go ahead and remove the pigtail and put a Foley catheter or a Cook stent inside the uterus. This is another patient similar to the previous one. This is another patient who canceled her IVF cycle before a failed transfer. Following the IR guided, she went on to have a live birth, actually. So who's a candidate for the possibility of having interventional radiology guidance? Patients with severe Asherman syndrome who have multiple surgeries and they keep failing. Patients with radical trachelectomy, which we see here quite a bit. There's no cervix to get in. There is no way you can put a hysteroscope without creating a guided access into the fundus of the uterus, because all the patient got is a fundus. There is no cervix to navigate through. If you have a segmental atresia, and if there are uterine wall agglutinations with prior treatment failures or prior false passages, if the uterus is markedly retroverted with prior perforations, these are patients that may benefit from interventional radiology guidance. So once you treat, you have to prevent readhesions. The risk of readhesions is high in the context of Asherman syndrome, and the two commonly used modalities are mechanical barriers in the form of cock-uterine stent or a pediatric 12 French Foley or 10 French Foley, according to what you can insert. We do not recommend using IUDs, whether it's copper or marine IUDs, to prevent readhesions for a variety of reasons. And there are some controversy about whether we should or we should not use adhesion barriers. This is a patient with extremely severe Asherman syndrome. Although we are mechanically restoring the normality of the endometrial cavity, as you can see here, it's very much a blanket white. You can't see any healthy endometrium anywhere. So this is a sclerotic endometrium. So once you restore the normality, you have to think of how you can maintain that cavity and prevents readhesions. And that is where we think about things like amniotic membrane grafts to be put inside the uterus. It's typically a dehydrated amnion obtained at elective C-section, sterilized with gamma radiation. It still retains the membrane structural and physiological and biochemical properties, and it is used in corneal surgery. So it's FDA approved for the eye, which is a more sensitive organ than the uterus. So these membranes are rich in epidermal growth factors or keratinocyte growth factors, laminin and type 2 collagen, and they act as a microscopic scaffold to allow the seeding of the endometrial basal stem cells that would help regenerate the endometrium. In addition to them working as a scaffold, they have TGF-beta, which inhibits fibrosis, so it decreases the risk of recurrence. It also reduces the expression of pro-inflammatory cytokines like interleukin-1 and releases the interleukin-10, which is an anti-inflammatory. Most importantly, they do not have a histocompatibility antigens. Consequently, they would not initiate graft versus host disease. This is one of the commercially available versions of this that's provided with an ophthalmic company for corneal surgery, as I said. And that is how it looks when we put it on the Cook stent at the time of the surgery after we lyse the adhesions. This is a series that was started in Cleveland when I was there before moving to Canada. And we found a 55% interval pregnancy rate on all patients less than age 40 and 12% pregnancy rate in patients above the age of 40. And everybody in this 35 patient series menstruated at the end. So post-operative assessment is mandatory because the recurrence risk can be up to 20, 30, 40, 50% in some series. So it is important to re-evaluate the uterus, and that can be done by either ultrasound or second look hysteroscopy according to your preference. And if you're bringing them for ultrasound, it's better to do it around day 13, 14, when you expect the lining to be at its thickest part at the end of the follicular phase. So there are some early reports about promising technology using stem cells derived from the bone marrow that's injected inside the uterus. The buzzword for these cells is they are CD133 positive, which means that they have the stem cell characteristics. And they are injected inside the uterus using embryo transfer catheters, followed by high-dose estrogen therapy. And there are, this is two case reports about spontaneous pregnancies. This is another series of 16 women that injected the stem cells using the uterine intravascular infusion system with 3 spontaneous pregnancies and 7 pregnancies with in vitro fertilization. So here's our protocol for managing severe Asherman syndromes, SIS or hysteroscopy to map the extent of the lesion with cervical pretreatment, 1 hour before surgery, buccal misoprostol would be enough. And then we do hysteroscopic lysis of adhesions with cold scissor under ultrasound guidance, under conscious sedation or paracervical block, followed by dilation up to 31. And then we do either Cook stent, distended with 6 to 8 centimeters, or a pediatric Foley catheter. And sometimes we have amniograft overlay for 2 weeks. And during that time, the patient is on antibiotics. We give 4 weeks of a high-dose estradiol, 4 to 6 milligrams, with 12 days of progesterone in the form of prometrium, 200 milligrams daily. Results are variable, but usually very promising if this surgery is performed well. This is a series of patients who underwent up to 3 hysteroscopic lysis of adhesions. Your best chances with the first surgery. So if you don't have enough experience, it's better to refer those patients who have experience, because that's when the likelihood of success is the highest, up to 80%, with around 20% risk of recurrence. With each repeat surgery, the likelihoods of success are less and less. Resumption of menses is reported in up to 90%. Term pregnancies for mild cases up to 81%. For patients less than the age of 40, 66% for moderate, and 31% for severe. So, ladies and gentlemen, I'm coming to my conclusions, and I want to tell you that Asherman syndrome is really preventable. You should do your very best to prevent them from happening. There is room for severe Asherman syndromes to use IR guidance and some physical anti-adhesion barriers, including the amniotic graft if they are available. High-dose estradiol with a 12-day overlay of progesterone are helpful to help regenerate the endometrium, although we don't have a lot of evidence, but it's a common practice. And other approaches such as stem cell restoration remain experimental at this stage. Thank you very much for your attention, and I wish you a fruitful meeting.